Melbourne. He's also completed additional training in image-guided procedural work at the Princess Alexandra Hospital. Jeremy's radiological skills and interests are broad and include musculoskeletal radiology, sports imaging, and interventional radiology. Thanks, Jeremy, for guiding us through this process.
Thank you for the introduction, and thank you everybody for attending tonight's webinar. Tonight's webinar is about the ankle and foot, and it's titled Put Your Best Foot Forward. My name is Jeremy. I'm one of the radiologists from IMED. I have a personal interest in musculoskeletal imaging as well as musculoskeletal intervention. I am currently working in Queensland in the Upper Mount Gravatt Clinic. So what we're going to go through tonight is an overview of the potential imaging modalities that we use in assessing problems around the ankle and foot. I will also go through some cases and imaging pathways as well as management options for those cases. Now, the ankle and foot is a complex joint, contains well over 30 bones, and has many potential problems that can go wrong with it. And there is obviously no way that we can go through everything that can potentially go wrong. So what I've decided to pick out are cases that are commonly seen in day-to-day practice and to talk a little bit about them. And then at the end, there will be a question and answer session, and there will be opportunities to go through any burning questions that you may have based on our presentation tonight or around the ankle and foot. Okay, so the imaging modalities. The obvious one and the most commonly used one is the good old venerable radiograph. It is a low cost imaging modality that is readily accessible. There is never any delays in booking. Everyone, when they're walking through a clinic, can get a radiograph done. It is very fast. It is fully rebated by Medicare in our clinics, and it gives excellent resolution of the bones, and it gives you a good overview of what is going on because you can see fractures, you can see dislocations or subluxations, and based on those findings, we can also look for signs of ligamentous and tendinous injuries that we would then need to go hunting for. Next imaging modality is ultrasound. Again, it is still readily accessible. In most of our clinics, I think the waiting time is about 1 to 2 days. It is usually fully rebated, so it's a low-cost imaging modality to the patient. It gives excellent resolution of soft tissue injuries, and depending on the probe, it allows you to visualize very fine details of ligaments and tendons. It is also a great opportunity for us as clinicians to have the ability to interact with the patient. So I would often take the opportunity when they come in, if it's a particularly tricky case, to take a history, do an examination before doing a targeted ultrasound study of the region to look for any potential problems. Now, like anything else in radiology in medicine, pre-test probability will guide post-test probability outcomes. So the more information you can provide us, the better targeted study we can do, and the more likelihood of us finding out what is wrong with it. And that's the beauty of ultrasound, is that it gives us the ability to look for potential causes before we even put the probe on the patient. In the right operator, it gives a great resolution and diagnostic opportunity. However, the limitations of ultrasound is that it is operator dependent. So potentially in the hands of a less experienced MSK ultrasonographer, we may not be able to see some of the structures that we need to see. Other imaging modality that is still relatively cheap and is fast and accessible is CT. Again, booking is relatively easy. The scan itself takes roughly about 30 seconds. It's usually the time taken to get on and off the table that chews up our booking slots. It gives excellent resolution of the bony injuries that sometimes we can't see on X-ray. For example, later on when we get to some of the injuries around the foot, if it's a small avulsion fracture on X-ray, it can be missed. However, in that situation, we would use other diagnostic modalities such as CT to better resolve it. Also, it has the advantage of having, for example, on a dual energy tube on the CT, it gives us the ability to use fancy reconstruction methods to reduce the metal artifacts. Say, for example, in a patient who has had surgery before and they're metal, it gives us the ability to do metal reduction. And also with dual energy tubes, it allows us to actually visualize things like crystal arthropathy and differentiate between a CPPD and a gout. Limitations for CT are that it is primarily designed to resolve hard tissue because it's an X-ray examination. In musculoskeletal work, it's difficult to assess small ligamentous injuries on CT because that's not what it's designed to do. For large tendinous injuries, we can potentially see it, but for small ligaments and also tendinopathies, it's much more difficult to assess on CT. And that's why we have the next tool, the MRI. MRI is probably the best modality for musculoskeletal work. Depending on the sequences that we use and whether or not it's fat or water-weighted sequences, it allows us to visualize both the hard tissue and the soft tissue. It also allows us to visualize cartilages, which is difficult to assess in all the other modalities. So MRI, with one study, allows you to look for fractures, look for tumors, look for chondromalacia, look for chondral wear, look for ligamentous tear, look for tendinopathies, and also look for any other areas that's causing inflammation, which will show up as edema on water-weighted sequences as a bright spot. The disadvantage of MRI is that it's because of the way the Medicare has been funded, it has the potential to attract more cost for the patient. It takes longer for the images to be acquired, and the patient has to be able to stay still inside the magnet. The other thing is that patients are often concerned about the noise and also the claustrophobia related to going into a tube. The good thing about MRI around the ankle is that their head and most of their upper torso stays outside the tube, so claustrophobia is less of an issue. However, the cost side of things remains the same because, as far as I know, Medicare does not allow GPs to refer for ankle MRIs under the current rules. It doesn't matter if it's a partially funded or fully funded magnet. Having said that, because ankle is such a complex joint, MRI remains the single best modalities for us to actually identify what is going on. And I will highlight some of the advantages of MRI over the other imaging modalities as we get to the cases. So nuclear medicine is the final modality that we use for imaging around the ankle. It's primarily used for infection and assessment of prosthetic loosening. It can also pick up subtle fractures. However, I think MRI remains the single best modality for assessment of subtle fractures because you can see edema around the bone, and then we can go looking for that subtle fracture using high-resolution CT. It can also be used in assessment of processes such as osteoma, and also looking for neoplastic processes and metastases by looking for tracer uptake. In areas where we have to look for infection and where it's difficult to assess infection from chronic versus acute with MRI or CT, we can use labeled white cell studies and look for uptake that way. Now, nuclear medicine has come a long way compared to the old days when it's just balls of fuzzy images with the overlapping functional and spatial images of the SPECT and PET CT. It's a much better study now for looking for small areas of abnormality. However, it's not often used in day-to-day imaging as far as the ankle is concerned. So now we're going to get to the cases. Before we start into the first case, we're going to go into the first question of the night. So, which of the following structures is an uncommon structure to be injured when the patient twists their ankle? Is it A, an ATFL tear, B, a CFL tear, C, a medial malleolus / medial talus bone contusion, D, deltoid ligament contusion / sprain, or E, an Achilles tendon tear? Now, the reason I'm asking this is because that's the next one that we're going to talk about, and it will highlight some of the things I was talking about with imaging modalities and why MRI is probably the best imaging modality to use. So I'll just give everybody some time to put their answers in. Okay, so out of all of these structures, it is actually the Achilles tendon that causes that is very uncommonly injured when the patient twists their ankle. All the other ones are what we always see when we have a patient who's been referred in for a twisted ankle. Okay. Inversion injury or an ankle sprain. Most commonly what you hear is they are wearing heels and they fell off their heels. They were walking and they fell down a stair and they twisted their ankle. Or in my case, when I did it about 2 months ago, I was looking at my phone and I wasn't paying attention and I slipped and I twisted my ankle and I messed up my ATFL. So the structures that are injured would be commonly the medial and the lateral malleolus. So what will happen is that you will invert the ankle and you'll pull off the tip of your fibula. So that's your lateral malleolus. And then you'll have a kissing contusion between the tip of the medial malleolus and the medial talus. Depending on how bad the twisting is, you can injure the talar dome and remove some of the cartilage or cause a fracture without causing displacement, or in the worst case scenario, take off the whole thing and create an osteochondral lesion, in which case an orthopedic surgeon will have to be involved, hopefully quickly, to reattach that to prevent serious arthritis later on down the line. Ligaments that are injured would include the anterior inferior tibiofibular ligament, anterior talofibular ligament, the calcaneofibular ligament, the medial ligament, and the anterior joint capsule. So when you're doing that inversion, what happens is the ATFL, which attaches between the tip of the fibula and the talus, that's what causes the pulling off of the tip of the fibula, and that ligament itself will get ruptured. A ITFL obviously is the one that everybody worries about in terms of high ankle sprain, and as we all know the Weber classifications that Weber sees and the involvement of the distal tibiofibular ligament and the widening of the syndesmosis is when we would refer to the patient to a surgeon to have surgery to make sure that syndesmosis remains congruent. The tendons that can be involved are often the medial and the lateral tendons. Don't often see tears in them from an inversion injury, but you can get related tenosynovitis with this type of injury. Now, in terms of the imaging pathway, what we often see in clinical practice is that patient will come in and the referral will say twisted ankle, fracture, and we will do the x-rays of the ankle using the AP and oblique views and the lateral projection. Now, in the previous scenario, prior to the current Medicare discouragement of self-directed radiographs, what we often do if we see a potential fracture, and our radiographers are very good at picking up fractures, is they will tell us that this patient has had a fracture. What else do you want to do? And we will say, that's great, good pick up. Let's do weight bearing views comparing the two sides. Now, I am uncertain as to what is currently happening, but from my understanding, the Medicare has started discouraging us from doing self-directed studies or add-on studies in addition to what is on the referral. So I'm not sure whether or not our old practice of saying, that's fine, let's go and get some weight-bearing views just to see if there's any syndesmotic widening is still kosher, or whether or not it would be better for referrers such as yourself to actually just put on plus or minus weight-bearing views. And the same thing goes for ultrasound. Now, in an acute injury, what we will see is the avulsion fractures that we talked about in the previous slide. You'll see the avulsion fracture from the tip of the fibula. You can see if it's a big Weber fracture. However, what we have difficult seeing on the X-ray and CT is the ligaments. The ultrasound is actually quite good at picking up injuries involving the AITFL, the ATFL, and CFL. So if we are at all worried about the integrity of those ligaments, and usually the ATFL is always involved, it would be useful to also refer the patient for an ultrasound study at the same time. That allows us to say definitively whether or not the patient has a high angle sprain, if that is one of the things that people are concerned about. It also gives us the opportunity to grade how bad the injury is, because a sprained ATFL versus a ruptured ATFL will have different management outcomes. You would rest for much longer and potentially consider strapping and icing for much longer, and they may need physiotherapy later on to strengthen the supporting ligaments and tendons once the acute episode has passed to prevent further injuries down the line. Now, X-ray and ultrasound, what they cannot do is tell us whether or not they have injured the cartilage at the same time, which is why, again, MRI remains the best imaging modality to look for all of those things. You'll be able to find the fractures, you'll be able to find the ligamentous injury, you'll be able to grade the injury, and you'll be able to assess the talar dome and the tibia bifida for chondral injuries. CT, in my opinion, has a role. It gives better resolution of small avulsion fractures, but apart from that, you can also see severe injuries involving the ligaments, such as the ATFL. However, because usually when it's acute, everything is edematous, everything is swollen, there's joint fluid everywhere. Its ability to resolve those ligaments is limited, and I think the role for CT in this situation is much more limited compared to the other ones that we've talked about. Now, another one that not every clinic has, but I know for certain that Dr. Andrew Rothstein and the team at Victoria House can do and often do is 4D CT to do dynamic stability studies to see whether or not the distal tibial fibular syndesmosis is congruent. What often happens is the patient would have had a sprain injury, and the AITFL would be injured, thickened, edematous, and what have you. And when they go and see a surgeon, or when they see a sports physician, or when one of the referrers look at it and go, I'm not sure just how bad the sprain is, what we can do then is use 4D CT to see on weight-bearing view how much it widens. And depending on how much it widens, that would determine whether or not they would need surgical intervention. Not every clinic has it. Certainly the clinic I work at currently down in Queensland does not have that ability, but it is a great problem-solving tool for stratifying the patient between surgical pathway and conservative therapy pathway. So these are radiographs giving you examples of Weber fractures. On the left, you have a fibula tip fracture, horizontal fracture with overlying soft tissue swelling. In this situation, you don't see any avulsion injuries involving the tip of the fibula, but even so, you can rest assured that the ATFL is probably ruptured and the CFL is probably injured as well. On the right, you can clearly see that there's syndesmotic widening in the medial clear space is widened, and there's a oblique fracture going through the distal fibular shaft, probably involving the syndesmosis. And in this situation, this is when we start getting concerned about, one, the integrity of the AITFL, two, possible osteochondral injuries. In this situation, we don't see any osteochondral fractures or osteochondral lesions or displayed lesions, but whether or not there is actual chondromalacia or chondral contusion associated with this injury, very likely. And this would be one of the ones where we would, in our report, go recommend MRI. So using X-ray alone, what we can tell you is there's a fracture, there's probably ligamentous injury, there's probably chondral or potential for chondral injury. What we can't tell you is exactly how bad it is. Now, using ultrasound, if the patient came in at the same time the referrer has asked for an ultrasound, we can actually look at exactly how bad the injuries are to those ligaments. The good thing about the ankle joint in inversion injury is that the ligaments are all superficial and we can assess for it. So the top left here, what you can see is that the ATFL is basically gone. There's avulsion fracture fragments. The tendon, which is supposed to look like this, you've got striations and the band, that's gone. That's completely gone. You can't see any of it. So we can say that the ATFL is ruptured. The AITFL here, that's thick, that's dematous, and you have lost its normal striations or fibrillar pattern. So this is a sprain. However, it's still intact. So this would be one of those cases where we would go, let's go and get a weight-bearing study just to see how much widening we've got at the syndesmosis. And depending on how much widening there is, we would recommend orthopedic opinion or not. And then the last one is the CFL. And CFL, it attaches from the calcaneus to the tip of the fibula and is often injured at the same time when you have an ATFL injury. And in this situation, it's a little bit edematous, but you can still see intact striations. So going back to what I was saying before, if at the same time we have X-ray and ultrasound, it gives you a much better clinical picture of just how bad the injury is, because twisted ankle is not the same for everybody. Some can be, it's just a sprain. Others can be, we really need to go and see a surgeon now. But if we have the ability to do both X-ray and ultrasound, it gives us a picture of both the hard or the bony injuries and the soft tissue injuries at the same time. And then we get to MRI, which is the best modality for looking at this. Now, in the same, well, this is not the same patient, but it's very similar injury pattern of injury. What we have here is a typical MRI of a twisted ankle. You have contusion between the malleolus, medial malleolus, and the talus. You have a contusion of the lateral talar dome with a small undisplaced fracture and surrounding bone edema. And this particular fracture will be very difficult to appreciate on X-ray. And then what you have is, this is the AITFL. It's thickened, it's edematous. There's surrounding soft tissue edema, but it remains intact. There's still some superficial fibers that is not completely torn off yet. So this will be a sprain injury. And I would call that probably a moderate to a high grade sprain injury, just given how edematous it is. And then the last one we come to is the ATFL. So the ATFL is basically gone. You can still see some intact fibers, but most of it is gone. And this is probably going to be functionally complete rupture. And also we can see the medial ligament, which is crushed between the two bones as they come together, and it's edematous. You've got some loss of normal fibers here. In this particular picture I've picked out, you can't actually see the avulsion fracture or edema of the fibular tip, but what you can see is you can see part of the ATFL near here, and that's edematous again, as I was saying before. So as you can see, with one study, you can get a lot more information, and you can get information on structure that's potentially missed on the other imaging modalities. So this thing here in particular. the osteochondral lesions that we don't think about. But with these lesions, if it's missed, later on down the line, the patient will get early onset arthritis and they will have loss of function. They will have ongoing chronic pain well and truly after the soft tissue injuries has resolved. So I think if in doubt, MRI remains the best modality, despite the fact that it seems none of our primary referrers can refer for them under the current Medicare rules. It does save time, and it does mean that if there is, for example, a displaced osteochondral lesion, it saves time for them to go backwards and forwards, getting one study after the other. It gives you it saves time for you at the primary point of contact. They don't have to come back and go, my ankle still hurts, what's going on? It gives you answer and gives you confidence about what to do next. So the next condition we're going to talk about is the inversion plantar flexion injury. Essentially, the mechanism of this injury is that instead of just turning the ankle inwards, there's turning of the ankle and also rolling the ankle forward at the same time. So in addition to the structure that we've previously discussed, all the Chopard joints come into play in this injury mechanism. That would include the anterior talus, the dorsotalonavicular joint, the anterior calcaneus, the calcaneocuboid joint, and cuboidal-navicular joint, as well as the posterior tibial plafond. Essentially, it opens up those anterior joints and causes avulsion injuries of the ligaments and the bones involved. And as you can see on the slide, the ligaments involved are the dorsotalonavicular ligaments, dorsocalcaneocuboid ligament, the bifurcate ligament, and the spring ligaments. Now, the ligaments are the important part about this injury because what we can see and cannot see without going to a MRI will become quite evident next. So, imaging pathway. Same as inversion injury, if you're suspicious based on mechanism or examination findings of this kind of injury, we can take an x-ray of the ankle to look for avulsion fractures. We can use ultrasound to assess some of the more superficially located ligaments, such as the dorsal talonavicular ligament and the calcaneocuboid ligaments. The deeper ligaments, such as the bands of the spring ligaments, as well as the bifurcate ligament, are difficult to assess unless you are at a center where it's specifically musculoskeletal focused and the sonographers are highly trained to look for those ligaments. CT can help to look for avulsion fractures that may not be readily apparent on X-ray. And this also helps if there are any joint space widening or subluxations of the Chopard joints, which will indicate to us that there is an underlying ligamentous injury. However, as we said before, MRI remains the gold standard for assessing ligamentous as well as bony injuries for this type of situation, because it will help identify any sprain or tears that is associated with this injury, specifically the bifurcate ligament and the spring ligaments. It can also assess for bone contusions that are called to X-ray intersettings that are called to CT. And also, it's the only modality that really allows us to look at the cartilages. So if there's any associated osteochondral injuries, MRI remains the best imaging modality. So, X-ray. These are some X-ray examples of what happens when you have an inversion plantar flexion injury. On the left-hand side here, you can see that there is a fracture involving the anterior calcaneus. This is also where the bifurcate ligament originates and attaches on the cuboid and cuneiform cuboid and naviculum. In this kind of injury, would be highly suspicious that there is an underlying ligamentous injury, and we will be recommending an MRI. On the right-hand side, you see an avulsion fracture involving the dorsal naviculum, and that would mean that there is probably an injury involving the dorsal talonavicular ligament, and any other associated injuries would be better assessed with MRI. This is ultrasound examples of those ligaments we're talking about. This is the talonavicular ligament. You can see that it is bowed. There is loss of normal fibrillar pattern. It is edematous, indicating that this is at least a moderate grade sprain injury. And on the bottom here, this is the calcaneocuboid ligament. This is actually intact. You can see how nice and thin and hypoechoic it is. What you cannot see, and I don't have good examples of it, is the spring ligaments and definitely the bifurcated ligaments. So go into the next slide. This is MRI examples of those two same ligaments we were talking about. This is the dorsotalonavicular ligament. Again, you can see that it is expanded, edematous with loss of normal fibrillar pattern. And over here, this is where the bifurcated ligament is. And if you imagine, this is the anterior part of your calcaneus attaching onto the cuboid. It is deep. It is difficult to visualize on ultrasound. And this is why MRI, I believe, is the best modality for imaging if you're suspicious for this kind of injury. Okay, so the next condition we're going to talk about is one of the don't miss injuries. It's the Lisfranc injury. Mechanism for this injury is variable. Often we see them in motor vehicle accidents. Say, for example, you're stomping on the brake before you run into somebody in front of you, and you run into the car in front of you with hard enough force that it starts injuring that Lisfranc joint. Or alternatively, you could have fallen onto your foot, or in sporting injury, you can be plantar flexing and twisting your foot at the same time, and those can all lead to Lisfranc injuries. Patients often present with midfoot pain, centered on the first and second metatarsal bases, and they cannot walk it off because it just keeps hurting. And the structures that are involved would include the base of the first, second, and third metatarsals, the cuneiforms, the cuboid, and to a certain extent the naviculum as well. Ligaments are 3 bands of ligaments involved in the Lisfranc joint. There's the dorsal band, the interosseous band, and the 2 plantar bands. The interosseous is also often considered the Lisfranc ligament proper, whereas the dorsal band is the one that is most susceptible to injury. And luckily for us, it is also the one that is accessible on ultrasound. So in terms of assessment, imaging assessment for this kind of injury, we would recommend that when the patients come through for investigation, we would do X-ray studies, and we would do comparison views with weight bearing. And also we would do an ultrasound to visualize that dorsal band to see whether or not that's disrupted, as any kind of injury to that dorsal band is a good indication of any other underlying serious injuries. CT is useful in Lisfranc injuries because sometimes subtle avulsion fractures involving the base of metatarsal and the cuneiforms can be difficult to visualize on X-ray. So in equivocal cases where we've got subtle widening, we would often go to CT to see whether or not there's avulsion fracture fragments. And if there are, we would then go to MRI to look for Lisfranc ligamentous injury. Or alternatively, if your patients are happy about out-of-pocket cost and you want to reduce the time to diagnosis, we can always do an MRI, which will tell us 1, where the fracture fragments are, 2, if there's any bony edema, and 3, if those ligaments are intact. So this is an X-ray example of weight-bearing views of both feet. This is a delayed presentation for a Lisfranc injury. The patient has been having ongoing midfoot pain when they presented. And as you can see, the actual joint space widening is quite subtle. Okay. Here is the base of the first and second metatarsal, and this is the affected side, and it is subtly widened. And it's only detectable on weight-bearing views. There's no obvious fracture fragments. What did tip us off? Number 1 is history, and number 2 is the fact that if you look at the bone on the right foot here, you can see how it is actually lucent, diffusely radiolucent, and that's indicating that the patient is having disused osteopenia because they're probably not weight bearing on it as often as they can because of pain. This is an example of the same injury on CT and MRI. On CT, you can see that there are small, subtle avulsion fracture fragments indicating that there is injury of the Lisfranc ligaments. And on the MRI, you can see that the ligament itself is actually disrupted and there is adjacent subtle marrow edema. Okay, so that's all our traumatic injuries. The next things I'm going to talk about is stress reaction. Stress reaction is one of those conditions that is a cause for chronic pain. It is a condition that may not often be at the forefront of our considerations when we're thinking about differentials for chronic pain. And it is also one of those conditions that unless the reporting radiologist is thinking about it, we can often miss the subtle findings of. Stress reaction comes about if the patient is having chronic, repetitive, continuous loading forces. So say, for example, a marathon runner who is avidly training for their next big run, and they've been training religiously for the last 6 to 12 months, especially during lockdown. They're taking that 1 hour time to do their runs, get their exercise in, and then suddenly they have worsening pain that they just cannot shake. That would be suspicious for a stress reaction. Now, location of stress reactions often involves the distal fibula and tibial shaft. It can involve the posterior calcaneus. It can often involve the metatarsal shafts and also at the head of metatarsals, and eventually can turn into avascular necrosis and collapse of that articulate surface. So in terms of imaging pathway, what we can do is when they come in for a potential stress reaction, we can do an X-ray to look for established stress reaction or signs of established stress reactions. So for example, sclerosis, smooth periosteal reaction, and possibly a stress fracture. However, X-ray is not great at picking up subtle signs of stress reaction. And for that, we have ultrasound. So ultrasound can actually visualize subtle periosteal reactions. It will show up as an area of increased echogenicity with surrounding soft tissue hyperemia. It is far more sensitive than X-ray. You can pick up low-grade stress reactions on ultrasound if the sonographer is actively looking for it. So this is another example of which if we have a higher pretest probability or we are suspicious of it, we're going to go hunt for it and most likely find it. But if we're not looking for it, possibility is that we're going to miss it. However, on MRI, this is one of those conditions that is very difficult to miss, because what you will see is you will see a rim of increased T2 signal around the cortex of the affected bone. And you are going to see a periosteal reaction surrounding soft tissue edema and possibly marrow edema as well. MRI is also very useful for grading of the stress reaction and can guide management options later on. So here are some X-ray examples of stress reaction. What we have here is your classical Freiberg infraction, where you've got collapse of the head of the metatarsal and subchondral lucency. Here is an established stress reaction of the fourth metatarsal shaft, where you've got thick laminated periosteal reaction. No stress fracture yet. And here is another stress reaction where you've got a band of sclerosis involving the posterior calcaneus. This is the same thing on ultrasound. What you can see is you can see subtle areas of increased echogenicity at the affected cortex with surrounding hyperemia. So these blobs of normally should be color is indicative of increased blood flow, hyperemia, and inflammation. And you can see how subtle it is compared to, say, a normal cortex over here. It's really quite subtle. So if we're not looking for it, likelihood is we're probably not going to see it. Here is a stress reaction. This is a high-grade stress reaction on MRI. You can see that you've got the periosteal reaction, marrow edema, and possibly a small undisplaced stress fracture here as well. But compared to the other modalities, this is much, much easier to detect. Now, this is a graph, a cartoon that I lifted from Radiopedia, so thank you to the author who made this graphic. It is the Fredrickson classification system for stress reaction on MRI. There are many different flavors of classification system on MRI, and this is one of them. And they're basically variations of the same thing. Essentially, what you have is you have low grade, grade 1 stress reaction, where it's just periosteal edema. There's no periostitis yet. That is detectable on MRI. And then what you have is you have marrow edema that is detected on fluid-weighted sequence or T2 sequence only. Following that, as it gets worse, you'll start to see the marrow edema on both T1 and T2 sequences, or fat and fluid-weighted sequences. And then as it gets worse, you're going to start seeing signal within the cortex itself and possibly a stress fracture. Now, why is this important, and why is MRI useful for investigation of suspected stress reaction? Because in terms of management of stress reaction, what you need to do is unload the stressors that has been put onto that bone. And that means resting, okay, stopping them from doing what they were doing before that caused this in the first place. So every single grade means approximately 3 to 4 weeks of rest. So grade 1, 3 weeks, grade 2, 6 weeks, grade 3, 12 weeks, grade 4, 16 weeks, essentially, breaking it down to simple terms. Now, because of the way it's loaded, sometimes it may be useful to refer the patient on to an allied health professional, such as a physiotherapist, or to one of our sports physician colleagues who are better at managing these things. But MRI is very useful at guiding management. Okay, next what I'm going to do is I'm going to go through some of the common conditions that we see day in, day out. The first of these is the Achilles tendinopathy. So usually what will happen is the patient can come in acutely or chronically. They may have done something to it recently while they're doing exercise, or they may come in with long-standing posterior ankle swelling that is painful. And essentially what it is inflammation and thickening of the Achilles tendon. Structures involve, number one, Achilles tendon, obviously, because you will see tendon thickening, and depending on how bad it is, you can see tendon tears and also evidence of inflammation. However, X-ray can be useful in assessing Achilles tendinopathy because there might be other contributing factors that's causing it. In this situation, I personally think that MRI's role is probably limited, because other than the fact that it is better at finding subtle signs of tendinopathy and better visualizing intrasubstance longitudinal tears, you can get most of the information from ultrasound and X-ray alone. What MRI does help, though, is that in equivocal cases where you're not sure what's causing it, it gives you an overview of the whole posterior ankle and look for other potential causes for posterior ankle pain. So these are X-ray examples of Achilles tendinopathy. So this patient on the left have severe encephalopathy, thickening of the Achilles tendon, and also a Haglund's deformity. So the Haglund's deformity is probably what's contributing to the Achilles tendinopathy. Patient on the right has a significantly thickened Achilles tendon that is readily appreciable on X-ray alone, but apart from that, not much else we can add to it on the radiograph. On ultrasound, what you will see is you will see thickening, loss of normal fibrillar pattern, hypoechogenicity, and if we turn on color, you will see hyperemia. And on this one, you can also see the enzyopathic bone at the attachment. If there are small hypoechogenicity within tendon substance itself, such as the small hypoechogenicity linear signal, that indicates that there might be underlying intrinsic micro tears, and that's something that's worth considering when it comes to management options. Obviously, if there is a rupture of the Achilles tendon, you'll see the whole thing retract up, and you'll see a fluid gap where it's discontinuous, and that's when we call our surgical colleagues. So on MRI, again, you get the same information where the tendon is expanded, it's edematous, there's surrounding soft tissue edema, associated marrow edema at the attachment. Here you can actually see a big longitudinal split tear going down the tendon itself. And here you can see a Haglund's morphology where it's probably contributing to the problem. And obviously you can see the rest of the ankle because it shows those structures beautifully. Now, this is the second question of the night. Before we get to management options, which of the following are potential risks of treating Achilles tendinopathy with a steroid injection? A, insomnia. B, focal fat necrosis. C, tendon rupture. And D, elevated blood glucose levels. I'll give everyone some time to put their answers in. Okay, so this is actually a trick question. The answer is all of the above. There are all risk factors that are related to steroid injection. However, in terms of Achilles tendon, the most important one is probably C, tendon rupture. Cortisone injections actually softens the tendon. So in terms of Achilles tendon and its significant function, if we do an injection and there are already pre-existing problems with tendon and existing weaknesses, chances are there's an increased risk of inducing a tear and potentially a rupture. The other options, insomnia. Some patients may be more susceptible to the effects of systemic steroids and they may have problem on the night of injection. Elevated blood glucose level is one of those things that if the patient is diabetic, they should always be warned about because it can throw their blood glucose level haywire and they may have to look after their insulin injections more carefully. Focal fat necrosis is one of those things that is more prevalent in the pediatric population, but what happens is it actually causes a large defect afterwards and cosmetically can be quite disfiguring. So, Achilles tendinopathy management option. I personally believe that if we are not dealing with the underlying problem that caused the tendinopathy in the first place, we can do injections and it's just going to come back. So, personally, I believe that sending the patient to our allied health colleagues for definitive management, either by offloading or strengthening exercises, is quite a useful thing to do. Alternatively, we can potentially do cortisone injections. However, my personal view on cortisone injections in that region is that I would be quite cautious with the injection given the potential outcome. And my personal view is that injections probably should come from a specialist referral, but that's just my personal view. We often get referrals from our surgical colleagues for peritoneal stripping as well, and that's something that can be quite useful in management of Achilles tendinopathy pain if it's chronic. But again, that's not something that we do frequently. And the other thing is, given the fact that cortisone injection can lead to potential rupture, and the fact that with tendinopathy, what you can get is micro tears within the tendon itself that is not always evident on imaging or examination. Plasma-rich protein injection is another treatment option that is worthwhile of consideration because, one, it doesn't cause most of the risk factors associated with CSI injections. And number two, it actually promotes tendon healing. So instead of just calming the inflammation down, we can actually infiltrate the plasma-rich protein into the tendon itself to promote tendon healing. Unfortunately, it is not something that Medicare has on rebate, and it's something that we have to discuss with the patient in terms of risk versus benefit and outcome. Okay, next one is plantar fasciitis. So plantar fasciitis, the patient can often present with posterior ankle pain. It is what you'll see on imaging is thickening and inflammation of the plantar fascia plus or minus tears. X-ray, again, what you will be able to see is often changes associated with chronic fasciitis, such as endopathic spurring. And it's potentially useful for looking for any other causes for posterior ankle pain. But in terms of assessing for the fasciitis itself, it's of limited benefit. MRI, again, can better visualize the intrasubstance tears inside the plantar fascia itself, and also can help in visualizing other potential causes for posterior ankle pain, especially plantar aspect, such as entrapped neuropathies. So here are some imaging examples of plantar fasciitis. So on X-ray, really all we're seeing here is endopathic spurring. The plantar fascia itself is difficult to visualize. We're not seeing significant thickening. On MRI, you can see that same bone spur with expanded fascia, edema, and intrasubstance tears in near the aponeurosis. And on ultrasound, we see a asymmetrically expanded plantar fascia with loss of normal fibrillar pattern. It's edematous, it's hypoechoic. We can't appreciate specifically the small intrasubstance tears, which is why in some situations consideration with MRI may be useful. And again, plantar fascia treatment option, our allied health colleagues in podiatry are very helpful in terms of definitive management by offloading the patient and offloading the strain that's causing the fasciitis in the first place. We can offer cortisone injections around the fascia to help reduce the inflammation and help our colleague in any physiotherapy or any offloading that they may need to do. And again, plantar fascia is another potential target for PRP injections for the same reason as the Achilles tendon. There's less risk of localized fat necrosis, and it can help promote healing if there are any split tears present within the fascia itself that may not be visualized on imaging alone. So when I'm doing these injections, what I would often do is I will numb the whole area down with local anesthetics, pass the needle into the fascia itself, and very gently just infiltrate a small amount of PRP into the fascia. And if the fascia starts opening up, split tears without me pushing, that means that there's actual tears, and that way I will infiltrate into the plantar fascia to help promote tendon healing and then inject the rest of it around the plantar fascia. And what we can often see when we bring them back for follow-up imaging is that we can start to see those areas of intrasubstance split tears become more echogenic and more linear echogenicity, indicating that we're starting to get some scarring in those split tears. So again, downside for that therapy option is that there is no Medicare rebate. Again, discussion with your patient as to benefit versus costs. The last one we're going to talk about is the bursal neuromal complex, or Morton's neuroma. The patient often will present with forefoot pain, and they will say that, oh, it feels like I'm walking on pebbles all the time. Doesn't matter what I wear or what I do, it just feels like there's something stuck there. Okay, and the patient, it's often caused by long-term wearing of high heels or very tight shoes. And what it does is that it causes inflammation and thickening of the intermetatarsal nerve, as well as inflammation and thickening of the surrounding intermetatarsal bursa, hence the name bursal neuromal complex. One thing of note is that Morton's neuroma, or bursal neuromal complex, doesn't really affect the first and second metatarsal, the interspaces between the first and second metatarsals. We really only see it between the third and fourth, second and third and fourth, or the fourth and fifth. If the patient is presenting with symptoms between the first and the second metatarsal heads, chances are there might be something else that is causing the pain, such as simple bursitis, or alternatively, it might be an impingement symptom. So in terms of imaging pathway, X-ray is a little bit limited in what we can see. We can sometimes see splaying between the affected metatarsal heads if the bursal neuronal complex is large enough. Again, what it is useful for is to exclude any other underlying causes. Ultrasound is probably the #1 modality for visualization of the bursal neuronal complex. We would be able to look for the bursal neuronal complex, assess the size, and also look for any other causes such as plantar plate tear. And also, if need be, we can often do a treatment at the same time if it has been requested on the form, where we will inject cortisone into the bursal neuronal complex to help reduce the inflammation and potentially cure the problem. MRI, it's great at visualizing this particular lesion and also assessment of the surrounding structures. However, this is probably not one of the conditions where I would recommend going to MRI in the first place. So just some imaging examples. These are ultrasound images of the bursal neuronal complex between the third web space, where you can see that center area of thickened intermetatarsal nerve with surrounding hypoechoic bursitis. You can see how the head of the metatarsals are splayed. And you can see that with compression, it's not really compressing down, indicating that this is not just a simple bursitis. And then what we can do is we will slip a needle straight into this bursal neuronal complex, inject into and around it to reduce the inflammation. It's the same thing on MRI. So if you imagine that is the lesion, and that's where it enhances the surrounding soft tissues, enhancing because it's inflamed, and that's the center of the thickened intermetatarsal nerve. If you look at this, then you can probably visualize what it would look like on X-ray, where you have the two metatarsal heads splayed apart by this large neuroma. Okay, and as I said before, we can inject it. It usually is quite effective. Anecdotal experiences that within 1 to 2 injections, patients often get complete resolution of symptoms. If they're getting refractory symptoms, surgical colleagues may have to get involved, where they have to go in and cut it out. However, I think podiatry is also one of the very important disciplines where they can actually look at the definitive causes that led to the thickening of the intermetatarsal heads in the first place, and advice on changing footwear, on padding, on offloading. Okay, so that concludes my presentation for tonight. I will open the floor up to questions.
Now.
Thank you very much, Jeremy, for that amazing tour through the radiology of the foot and ankle. You certainly put your best forward with that, and we all appreciated it.
And I didn't trip this book.
Thanks to those that have asked the questions. We just want to apologise for a brief technical glitch getting that poll question displayed at the wrong time. But we haven't had any well wishers coming in, calling in saying that they are hoping your ankle was improving, but I hope it has got better anyway, Jeremy. Now, the first question is from Frances, and she says, is it always necessary to do an X-ray before an MRI? She asked that particularly when you were talking about this frank injury.
Sure. So not necessarily. It's actually quite useful to do an X-ray in conjunction with the MRI, because MRI is great at giving overviews of large fractures, and it's great at picking up small fractures by looking at bone edemas and subtle areas of sclerosis as fragments. However, X-ray is always appreciated. So when we're writing requests out, in the old days before Medicare started cracking down on self-directed radiograph requests, we would often actually ask for an X-ray at the same time if there are subtle areas of fracture that we're not sure about. These days, if you want to go straight to an MRI, it may be useful to do both on the same request, and then that way we can correlate between the two modalities and give you a better answer.
Okay, thank you. One of our Tasmanian colleagues has asked, is PRP injection performed at IMED, and Do you know if it's available in Tasmania? I doubt that you'll be able to answer that, I suppose.
All I can say is in Victoria and Queensland, where I've worked, we certainly do PRPs. In Victoria, we do them routinely at Vic House, and I think in Casey as well, they've got a centrifuge there. In Queensland, I know that we do them in Upper Mount Gravatt and Hurston. I don't know anything about Tasmanian services, unfortunately, and you're probably better off asking the local service providers about that.
Yeah, that makes sense. Debbie, one of the podiatrists, has asked that she's not sure how many structures she can ask to be assessed with an ultrasound examination under one Medicare referral, particularly if someone's got inflammatory joint disease. She wants multiple structures examined and measured. Is it reasonable for her to ask for all these things on one referral?
Yep. So realistically, you can technically assess the entire ankle in one ultrasound study, but technically it's challenging because the ankle is so complex. So for example, we prefer looking at things in compartments. So if it's the lateral compartment or the medial compartment or the heel, or for example, quite frequently what we get asked is the forefoot. And in the forefoot, when we're assessing, for example, in the forefoot, we would always go through everything in the forefoot. So, for example, we will look for Morton's neuroma, we will look for plantar plate tears, we will look at the sesamoids, and we'll look at the flexor and extensor tendons. That, to do a proper assessment, would take up usually the entire ultrasound booking. If we then have to start going back to the other areas where we're looking for those things, then it gets quite difficult, and chances are if the sonographer is not patient, he may rush through it and miss stuff. So our preference would be to actually do one area at a time if possible. Now, talking about inflammatory joint diseases, the things that we can see for inflammatory joint disease on ultrasound will be tenosynovitis of the tendon if it's involved, and also joint effusions. Better examination for inflammatory joint disease will be an X-ray to start off with, in conjunction with an ultrasound if you're worried about tenosynovitis. That would be how I would do it.
Thank you. Now, one of my podiatric colleagues from where I work has asked, do you ever recommend nerve ablation for neuroma, and what's your view on the contraindications for this?
So contraindication for nerve ablation is that you get sensation loss, and that's irreparable sensation loss. So my personal view on ablations is that you should try with a block first to confirm that it is the actual location and the cause for the pain. Following that, probably try it out with a long-lasting block to see how you go, and try it with exercise as well to see if there are any changes in sensation can lead to problems with your gait and the walking cycle. Then consider doing ablation. Now, people who do ablation are, I think, usually they're interventionalists, and they're usually done in the hospital setting because it's painful, and it usually requires sedation and anesthetic support. So it's a little bit more involved. It can be very good if it is cause for chronic pain, and it's a great management for chronic pain, but I think it's one of those things that once it's done, it's done. There's no going back from it. So go into it with eyes open. That's my view.
Maddie asks a very sensible question. Should imaging be done if it won't affect the treatment plan?
If it won't affect the treatment plan, no, I don't think so. I think at the end of the day, treat the patient, treat the symptoms, don't treat the radiology findings. We're here to provide a service to help, like I said before, in diagnosis and also in staging and help in treatment planning. So if it doesn't change the outcome, why waste the resource and the time? Yeah.
David asks, for an ultrasound-guided cortisone injection for bursal neuroma complex, can the injection be given dorsally, or are they usually given from the plantar aspect? Obviously, it's more comfortable dorsally.
Sure. So there are multiple ways to skin the cat, and there are different ways of doing a neuromal injection as well. Personally, I don't go dorsal or plantar. I go in between the toes, and that is actually the most comfortable way of doing it. So as long as you get to the right place, I guess you can do it whichever way you can. But that's the way I do it, which is going in between the toes. And yeah. So short answer, yes, you can.
Hilda asks, what is recovery like and the recovery period after plantar fasciitis steroid injection, PRP injection, and Achilles tendon injection?
Okay. So with cortisone injections, usually the local anesthetics last for around about 3 to 5 hours. Then it's going to wear off. Steroids usually kicks in after about 3 days or so, and that really starts to build up after a 2-week period. So what I tell my patient is that give it 2 weeks, monitor how it's going every single day at the same time, write it down, and if it's not getting better, then it's not going to work. And that's for cortisone injection. So that applies to, doesn't matter where you inject it into, plantar fascia, tendon sheath, bursa neuroma, etc., etc. PRP is different. PRP is pro-inflammatory. So if we're injecting PRP into a tendon, chances are the first 24 to 48 hours, it will be quite painful because of how inflammatory it is. And what I sometimes do for patients is I will actually give them a script for pain relief to go with it after the injection. The difference between PRP and steroid injection is that steroid injection carries the risk of softening the tendon, and you're at increased risk of tearing that tendon if you go straight into sports activity or weight-bearing activity right after. Whereas with PRP injection, there's no limitation on that. It's more limited to what you can tolerate. In terms of Achilles tendon, realistically, that I would leave it to the orthopod to decide what to do. I don't like injection around Achilles tendon because of the risk of rupture.
And we've had quite a few questions from podiatrists, which is excellent. One of them is, as a podiatrist, can we refer for a plus minus a cortisone injection, and is it rebated through Medicare if we refer, or should we refer back to the GP? I'm not sure if you know the answer to that, right?
I am not sure. We will take referrals. I don't know whether or not it will be rebated by Medicare, though. That I cannot tell you. I'm sorry.
Okay, now we won't be able to get to all our questions, but the commonly asked questions, we'll try to get some answers recorded on the IMED website so people don't miss out on things that they've asked. The last question is from Karen, a 60-year-old with cerebral palsy, clubfoot, lateral ankle pain. What do you suggest would be the best imaging modality or modalities?
I would recommend doing an X-ray and ultrasound to start off with. Following that, consider if we can find an abnormality on ultrasound to target, then we can further assess with MRI. The problem with the clubfoot on MRI is that there will be matter edema everywhere, and because of abnormal weight bearing and mechanical loading, the pattern of edema can be a little bit harder to suss out. So better way of doing this would be to have serial images of the foot so that we can compare what has changed and then target that area specifically to look for abnormalities. The other way to do it would be if we can actually assess them. And that's the reason why ultrasound is so good, is that when they come in, we can actually talk to them and assess them and look for the area that's causing the pain and then chase the structure in that area. So to answer your question, X-ray and ultrasound first. I would prefer to go into the room, have a look at the patient, and then based on what I find, then go on to other modalities.
Thanks, Jeremy. Thanks so much. Unfortunately, that's about it time-wise, but thank you for such an excellent presentation. We'll go back to Sue, who's got a few words to say.
Thank you.
Thanks very much, Phil. Thank you, Dr. Lin, for the very informative presentation tonight, and thank you very much, Dr. Pearlstein, for facilitating. Definitely any questions that we didn't get to tonight, we usually do a quick Q&A and we pop it on our website, and we also send you a link to these. So if we didn't get to your question tonight, certainly we will follow that up with you. I would like to thank you, the audience, for joining us tonight. I look forward to your feedback, so can I please ask you to stay on the line for a couple of minutes just to fill out that form? You'll be redirected shortly. So thank you once again. Stay safe, stay well, and good night.